Bismillahirrahmanirrahim. Today we are going to discuss the treatment of endometrial cancers. So basically, every year worldwide there are 4,80,000 people diagnosed with endometrial cancers. So in female mostly. So how do we treat endometrial cancer? Initially they present with vaginal bleeding after menopause, after 50 years of age, for 3-4 months, which are not associated with fevers or any dysuria, are associated with weight loss. So initially they undergo biopsy, curettage, after doing ultrasound. So when it come out to be positive for malignancy, they undergo staging, CT scan, CT chest, abdomen, pelvis, and bone scan. So once they undergo the complete staging, it's localized, they are advised to do surgery. And surgery, they undergo total abdominal hysterectomy plus bilateral salpingo-oophorectomy, plus pelvic lymph node dissection plus minus omentectomy based on the initial staging of the patient. Now once the patient undergo surgery, they are required to receive adjuvant treatment. So the adjuvant treatment, today we are going to discuss how we radiate the patient, and how the patient are planned for radiation, and how they receive external beam radiation therapy or whole pelvis radiation therapy. What is the planning system, and how we make the plan for the patient after undergoing surgery. Now once this patient has underwent surgery, and in surgery her tumor was in present in the uterus and involving the serosa. So involvement of the serosa make it is a stage 3A. So once it is a stage 3A, the patient is required to receive adjuvant radiation therapy, external beam radiation therapy, uh, followed by brachytherapy. So in this patient we are going to discuss. So once the surgery has been done in this patient, after surgery she is required to receive external beam radiation therapy followed by brachytherapy. So how we planned external beam radiation therapy in this endometrial cancer to treat her radically and completely cure her from cancer. So we do CT planning with contrast. So this is the CT planning with contrast for this patient with IV contrast, in which we have included her whole body along with this is the CT scan of the patient. You can see we have included the lungs, the liver, and the abdomen, the kidneys, and then the pelvis of the patient, and we are seeing that there is no abnormality or metastasis present in this patient. So after that we mark the patient. So once we are marking the patient with so how we mark this patient, initially we make the stump for this patient. So in this patient we make the stump for this patient. So this is the stump of the we have made in this patient. So this stump is in between the bladder and the rectum. So this is the leftover stump of the hysterectomy or the uterine cervix we have remaining. So you can see it is in between the bladder. This is the urinary bladder in this patient. You can see this is the urinary bladder, and this is posteriorly it is uh, uh, with the rectum. So posteriorly this is the rectum and the bladder. So initially we draw the stump of the patient. So this is the clinical target volume for the stump. Then we give extra margin to the stump, and we call this is a PTV. This is the, we have given 1 centimeter margin as per EVIQ guidelines. So this is the 1 centimeter margin given to the stump. So we are going to radiate this stump and this extra margin. So this is the 1 centimeter extra margin from this stump. You can see the red one is the stump, and this blue, dark blue color is the extra margin planning target volume given to the clinical target volume of this stump. So this is the 1.0 centimeter or 1 centimeter extra margin given to the stump, and this is the planning target volume of this stump. After that, as the initial stage of the patient was stage 3, so she is required to receive radiation therapy to the pelvic lymph nodes as well. So how we have drawn the pelvic lymph nodes, it is these pelvic lymph nodes. So the pelvic lymph nodes begin from the L1 L2 vertebra. So you can see this is the L1 vertebra, and from this L1 vertebra we have begun its contouring. So this is the psoas muscles, it is present and to interior of the lumbar vertebra. So medial to the psoas muscles and anterior to the vertebra, this common iliac lymph nodes are present. So then you can see we go downward. So now the lymph nodes are divided into external iliac lymph nodes and internal iliac lymph nodes. So these are internal, external, and internal iliac now common. Now we have come down internal iliac lymph nodes up to the obturator foramen. So these are the obturator foramina of this patient. So this pelvic lymph nodes have been contoured to the obturator foramina, or we can draw up to the to the heads of the bilateral femur. So the contouring of the internal iliac lymph nodes include the head of reaching up to the head of the bilateral femoral heads. So now we have given extra margin to the pelvic lymph nodes, and we call this as a planning target volume. We have given 0.8 centimeter margin to this pelvic lymph nodes, and this is the PTVN or planning target volume, and you can see this pink color is the planning target volume for the nodal station, and you can see that it is covering the common iliac, external iliac, internal iliac lymph nodes reaching to the obturator foramina or the head of the femurs. So after that we have drawn the PT 45, and you can see this is the region which is going to receive the 45 radiation therapy. So we call it as a whole pelvis radiation therapy with extended fields. With extended field mean that we have included the common iliac, external iliac, internal iliac lymph nodes reaching up to the obturator foramina. So this is the planning target volume 45 for this patient. So this is the planning target volume for this patient. Now after that we have made the organometries. So this is the left femur for this patient. So this is the femoral head, the neck up to the lesser trochanter, greater trochanter, and below 2 centimeter below the lesser trochanter is left femur and the right femur. And you can see this is the bowel bag, which includes this yellow volume is the bowel bag. So this yellow volume is 2 centimeter above our radiation area and 2 centimeter below our radiation area. So it contains the small bowel. So it is important to draw this because we are going to estimate the total dose radiation by the small bowel on dose volume histogram. So how we control this? Initially, this is the body of the patient. We have drawn the CTV stump. Then after that, we have given 1 centimeter margin to the CTV stump. So you can see this is the 1 centimeter margin to the CTV stump. Then after that, we have drawn the pelvic lymph nodes, which is the CT45. It begins from the L1 to L1 vertebra and reaching up to the femoral heads. You can see these are the femoral head, and the pelvic lymph nodes are beginning from the L1 vertebra and are reaching up to the femoral heads. So then we have given margin 0.8 centimeter margin to the pelvic lymph node, so then it becomes a PTVN, and we have combined this volume. So the CTV stump plus the planning target volume to the stump, and these volumes are combined with the pelvic lymph nodes volume, primary target volumes of the pelvic lymph nodes. So as a whole, we may have made a single volume of all of these, from all of these, and we call this as a PTV45. So this is the whole volume, which includes the lymph nodes as well as the stump area as a whole. So this area will receive a 45 gray radiation in 25 fractions. So this is the international recommended guidelines for planning for external beam radiation therapy for endometrial cancers. Now after once this patient completes the radiation therapy, she will be planned to receive brachytherapy of 4 fraction, and high dose brachytherapy will be done to this patient, in which she will receive 7 gray of radiation in 1 fraction, and as a total of 28 gray radiation in 4 fraction with brachytherapy. So this patient initiated the treatment for endometrial cancer. In this patient was as is she was stage 3. Initially she underwent biopsy and CT staging. After that, she has underwent a surgery in which total abdominal hysterectomy plus bilateral salpingo-oophorectomy was done, followed by external beam radiation therapy planning. So this is the external beam radiation therapy plan, and after that, once the external beam radiation therapy plan is completed for this patient, she will receive brachytherapy for 4 sessions, and so her endometrial cancer after that will be cured completely. Thank you so much. So after this, I will discuss the risk factors for how she developed. As we can see the obesity, so you can see obesity is the one of the risk factor for in developing endometrial cancer. So if we reduce the fat intake, fast foods, oils, and increase exercise, we can reduce the risk of endometrial cancer. Second, we can reduce endometrial cancer by taking good care of our hygiene. uh, Third, we can reduce the endometrial cancer by reducing the estrogen exposure. So estrogen exposure is reduced by having a lot of babies, because when a woman is pregnant, she is less exposed to estrogen as compared to a woman who is not pregnant, and so on. Thank you so much. If you have any questions, please ask in the comment section. I will answer all of those questions.